Good afternoon. Good afternoon, everybody. So really, thank you for joining us, even in the bad weather as we are in the really middle of a typhoon. All right, we're gonna start with a live case from the Asan Medical Center. So, as you know, so we have many distinguished moderators here. So Alan Yeung, David Cohen, Dr. Hayashida, Dr. Kim Joo-han, Young-Guk, and Nicolas van Mieghem. So really, thank you for joining us. All right, we're gonna start the first live demonstration case from Asan Medical Center. 그죠? Dr. Ahn, can you hear me?
Yes, I can hear you.
All right.
Yes.
All right. So we here we are. We have many distinguished moderators, faculties here. So would you start the first cases?
Yes. Good afternoon, ladies and gentlemen. Thank you for coming in the middle of a big typhoon coming. So we are in the Asan Medical Center. So we prepared the two cases for 1 hour. So first case and it would be the very two cases would be the educational and the fun for the live demonstration. I am Jung-Min Ahn from Asan Medical Center. This is Yeon Che, our senior fellow. Dr. Che will present the brief history of a patient.
Yes. Thank you for introduction. This patient is a 78-year-old female and she had admitted for DOE near class 2 and she underwent mitral valve replacement 25 years ago for mitral valve stenosis and had a permanent pacemaker implanted for shake sinus syndrome. The echocardiography showed severe AS with moderate AR and normal LV systolic function. On past medical history, as mentioned, she had permanent pacemaker and underwent mitral valve replacement with mechanical valve. Next. She has been treated with hypertension and the STS score is 5.55%. There is intermediate OP risk. Next. KG shows ventricular paced rhythm and the rate is 50 per minute. Next. X-ray shows cardiomegaly and implanted permanent pacemaker and there's no active lesion in the lung. Next. Echocardiography shows normal LV systolic function and aortic valve area is 0.4 square centimeter and mean pressure gradient is 79 millimeter mercury and transaortic valve Vmax is 5.8 meter per sec. Next. On color Doppler, we can see the flow acceleration at aortic valve level and moderate AR with the vena contractor is 4.4 millimeter. Next. Every contractility is within normal limit and the transmitral mean pressure gradient is 3 millimeter mercury and mitral valve area is 3.0. There is mitral valve is well functioning. Next. This is short axis view. You can see the calcification and fusion between non-coronary cusp and left coronary cusp. And aortic valve Vmax is 5.8 meter per sec. Next. This is transesophageal echocardiography. The area by planimetry is 0.52 and you can see the fusion between non-coronary cassette and left coronary cassette. Next. This is pre-procedural CT findings. Annulus area is 402. Annulus parameter is 72.6 millimeter. Next. Sinus to annulus area ratio is 2.15 and STJ to annulus area ratio is 1.42. They are large enough. Next. LVOT to annulus area ratio is 0.97. Next. Total calcium volume is totally 630, and we can see the calcium chunk between one coronary cassette and left coronary cassette. Next. She had mitral prosthetic valve, and annulus to mitral prosthetic valve length is 5.5 millimeter. Next. You can see the calcium chunk between the NCC and LCC, and there's some calcification on abdominal aorta and both iliac arteries. Next. This is coronary height. Left coronary artery height is 11 millimeter, and ICA height is 18. Next. This is iliofemoral arteries. Minimal diameter of right external iliac artery is 3.6 millimeter. It is small, and minimal diameter of left external iliac artery is 5.1 millimeter. So we consider left femoral approach. Next. This is a sizing table for SAPIEN 3. We prepare the valve size is 23. Next. This is a sizing for evolute. Next. Is coplanar view. Next. It's our TAVR planning in this case. Thank you.
Thank you very much for the very nice presentation, Dr. Che. So, do you have any comment or question on patient history and our TAVR planning?
Yeah, this is David Cohen. Hi, Jung-Min. Nice to see you.
Yeah.
How did you consider very much for a self-expanding platform, given how small her annulus is? There's a trial going on in the United States, the SMART trial for patients with small annuli. This patient certainly qualifies for that, and I would have thought hard about perhaps using a self-expanding and evolute FX for this. I think it also has nice feature that if there's any interaction with the mechanical valve, you can retrieve it also, which is always a little concerning.
Yes, yes, small annulus, the prospectus patient prosthetic mismatch would be a concern, but Dr. Hayashida may have more experience for such a patient. The Japanese patient would be smaller than the Korean patient, so that they published several data show that small valve implantation in the small annulus does not affect the overall long-term mortality. So in this patient, I don't consider too serious about the small annulus in this patient.
I agree with that statement, unless David has some insights on the SMART trial. So otherwise, we cannot say that one is better than the other in the smaller annuli. And at the same time, this was already mentioned in the morning session, there is this issue of discordance between echocardiographic gradients and invasive gradients. And oftentimes, invasively in the cath lab, you don't see a difference between evolute valves and SAPIEN valves. You only see it the day after when you do a pre-discharge echo. And then the question is, what correlates with outcome? And preliminary data from my side, and we are trying to get this published soon, is that not the transvalvular gradients by echo, but the invasively measured transvalvular gradients correlated with outcome. Yeah, and that obviously might also affect the interpretation of, for instance, the SMART trial.
I mean, certainly it will, because one of the primary endpoints for the trial is the one-year echocardiographic gradient.
Yeah.
How about the pre-dilation?
Particular these cases, anyway, the patient received mitral valve, mechanical valve concern, the distance between the aortic annulus and the mitral valve annulus is 5 millimeter something, and so is there any considering aspect in terms of selection of devices, self-expanding, balloon expandable for a particular patient?
And I think back, in the very early days when we were much less certain about where the valves would end up, I would have been concerned about putting a balloon expandable valve in here. 5 millimeters is a pretty good amount of clearance, and I think we could certainly put this at 2 or 3 safely. I don't think that would be a problem.
Nicolas?
Yeah, I agree with that. I think in the past I had predominantly issues with the core valve to make sure that I would end up with a higher implant. Obviously, you don't want to go too deep in the ventricle, but I think in these days with the current devices, I think we're in good shape with both systems.
So the mitral valve is a Seung-Jung bileaflet valve, so it's pretty low profile. So generally, you have room to really get pretty close without interfering it. So I think they should be okay with that 5 millimeter plus low profile mechanical valve.
So I would like to ask you that about the etiology of AS. This patient, based on the patient history and echo finding, the etiology of AS would be the rheumatic, not the typical degenerative AS. So do you have any experience for the TAVR in rheumatic AS patient?
I've never done one. I'm curious to watch.
70,
Yeah.
all right, 70, 80.
The question whether you pre-dilate it, because they're kind of sclerotic and they kind of like the mitral valve kind of stuck together. So whether you want to pre-dilate with the balloon first, that might help.
You mean
Yes, I fully agree with your opinion. I will do the pre-dilatation with the balloon. So because the calcification and volume is more than around the 600, so I will do the pre-dilatation. Could you show us the next slide? So I reviewed some short yes. So we have a similar case. The last week we did the rheumatic MS and rheumatic AS patient. 83 female rheumatic MS, previous PMV, but the PMV after PMV 10 years later, the mitral stenosis recurred and rheumatic AS occurred. So the last week we performed both the balloon valvuloplasty for mitral valve and TAVR in aortic valve. Next, please. Based on the echo show that definitely rheumatic MS, the aortic valve showed diffusion and some calcification. Next, please. So at the same time, simultaneously after the balloon valvuloplasty for MS, and we did the TAVR for AS. So next, please. Based on the U.S. data, Cleveland published the data about the TAVR in the rheumatic severe AS. So they gathered the 500. There is no significant difference between the degenerative AS in terms of long-term outcomes. But there should be a clinical challenges because the rheumatic AS is associated with the fibrosis and retraction and concomitant AR, and correlation of a symptom is not easy to specific the valve malfunction. So technically, we have to consider the less calcification, so some vibration and remnant paravalvular leakage. I'd like to show our procedure. So could you give me, we prefer the left femoral approach because the right external iliac artery is small. So I'd like to use the balloon expandable valve.
I have one question. I'm Young-Guk.
Yeah.
There is a small
Yeah.
calcified mass between SCC and NCC. Do you think it
Yeah.
affect? It may risk for the annular rupture during the balloon dilation of valve implantation. Would you consider to reduce the sizing, or do you have any strategy to?
So yes. So
avoid,
if we select the 23, so balloon overall expansion rate is only the 1% to something. So it's not too oversizing. So there is no serious concern about the annulus injury, I think.
So hello, Jung-Min. This is Kentaro. And
Yeah.
so could you please tell us your tips and tricks to cross the aortic valve with rheumatic degeneration?
So the wiring is sometimes not easy because it's different from the degenerative AS. The fusion makes the difficult wiring, but I think that we need to try and error.
Which wire are you using?
This is what's the name of this wire?
Is it an emerald
Ring
wire?
Toku straight wire.
It's 3-5 wire.
Okay. So I think the wiring, the more, I think catheter location is more important than wiring itself. So some operators pick the wire to the aortic valve, but instead I try to locate the catheter, guiding catheter tip to the opening of aortic valve.
Is that a guiding catheter, Jung-Min?
It is an implant.
AL1 guiding catheter?
Yes, AL1. No, diagnostic catheter.
Diagnostic, right. I thought
Yes.
you said guiding catheter.
I'm sorry, my mistake.
Alan, do you have any experience about the uncrossable wire to the aortic valve?
Sometimes very frustrating.
Sometimes.
Sometimes you have to take a break and then try again. So
How
my
many?
first,
How many? Well,
I never had one that we couldn't cross, but sometimes it takes a while and you have to sort of take a little break and take a breather. But I think the key is really to, sometimes you can see it's a random process, but at the same time there's a methodology to it. That you're actually trying to get to a view that you think from CT that you have the best chance of crossing. And then you go into the right cusp and you kind of, manipulate the catheter in such a way that it points down. And then you kind of move it back and then now the wire would go into the left cusp and then you basically go in between and try to aim for that center. And most of the time works. So I use, hydrophilic wire first, and then I use an emerald wire, which just gives a little bit more body to go through. And many times, sometimes you cross and then you do it too fast and you come back before you know it. So that's the frustrating part. But if it cannot be done, let's say absolutely cannot be done, then I think in the future there might be more of these cases in after TAVR valve. Because after the TAVR, the valve leaflets could be a little kinked in different ways. You may not find a hole. So then it becomes very challenging. Then you might have to do something through antegrade, meaning do a transeptal approach, go to left ventricle, try to come back out, snare that, externalize it, and change it. But that's obviously much more headache and much more complicated. So
I think it's a very good technique though that you need to know when you can't cross, because again, we had a case where we tried for about an hour and we couldn't cross it. Many different catheters, many different wires, and we did the antegrade approach, and 15 minutes later, all good.
so David, did you have some cases?
Yeah, one.
Out of one.
So far. I hope I don't have any more, but
We also have one case like that. It works very well. So I agree with David. That's one of those skill sets that you might want to have in the lab.
Exactly. Say, the one cases out of 1,500.
Exactly.
Very first
I
beginning
think
of our experience.
those of us also do sort of transeptal mitral valve, then it's okay. But if as an operator that doesn't do that, then stop. Just there's no need to push it. Stop. You haven't crossed. Nothing happened too much, and come back. If you all ask someone to help, or if not, someone is available, then stop and come back again.
I think there's no rush, right?
Yeah, don't force something and make things worse.
어떤 would you do pre-dilation, right?
Yes,
Yeah,
predilation. So usually I like to use the smaller balloon. Don't damage to the aortic valve and the aorta. So this is what size? 16?
16.
18 G-med balloon. So facing on. inflation,
Inflation.
contrast, deflation,
Inflation.
pacing off.
Is this patient under general anesthesia?
No, the cautious sedation.
Okay.
So our anesthesiologist is not available, so our Catholic nurse is in charge of make her sleeping.
Just the deep sedation. All right. So what did you do? Balloon expandable, self-expanding? What did you?
Balloon-
Your choice.
Yeah, both are available, but I'd like to use the balloon expandable device.
Would anybody do this case with, with general anesthesia and TE, just to be very careful with the mechanical valve? Would you ever consider that, or not at all?
We wouldn't. I'm sure at Columbia University they would. He's very eminent, but we wouldn't.
No, we don't.
Again, in the olden days, that was, we would worry so much and want to be able to keep a very close eye on the mechanical leaflets.
So what size?
Okay.
SS3,
This is
Ultra,
S3 23.
20,
23.
23.
23. Just exactly, normal size.
Cool. Yeah, normal size. So could you show us previous balloon aortogram? We cannot exactly expect, but during the balloon valvuloplasty, the mitral valve, mechanical valve motion is very well. So there should be no mechanical interaction with the TAVR valve, and I believe that. Okay.
Flexion.
Can you change to the implantation view? Test, please. Test. Okay. Test. Okay. Yeah. Pacing on. Contrast. Inflation.
Inflation.
4.
Good.
1, 2, 3, 4, 5. Deflation.
Inflation.
Pacing off.
Always be to 5 seconds.
This is slow on
We do
Asan.
3.
Asan.
But count slower.
Very slow count sometimes. 1, 2. Inflation is one.
You can come faster, right?
Anyway, it's very, simplify the procedure during the last one.
Yeah. So David, what is your concern of the mechanical valve in mitral position? You think it will, if it's low, what will happen? That it would in a mechanical one, right? So
Again, theoretically, you could,
Ready?
freeze the leaflet, I think, if you got too low. I don't think it would happen here with 5 millimeters.
right. But how would you freeze the leaflet? Why would the leaflet be frozen?
I'm not even sure how it would do. Again, there
Right,
are definitely
because-
cases where I've seen it.
Yeah, the 5 leaflets are basically
Yeah.
sitting in 2 pins,
Yeah.
and the 2 pins are floating down, floating up, and then have a big sewing ring. So
Would you
You would think it would not happen, but I just worry.
Not
I think
to-
one check is to see the orientation of the pin. If the pin is towards the aortic valve, then it could be that it pushes against the pin somehow and prevent it from opening. But if it's oriented 90 degrees or whatever degrees to it, then it shouldn't really do anything, even if you're a little low.
No, I mean, I think you're right in theory. I guess the problem is, what we've all learned over the years is anything you can imagine will happen eventually will.
Position-wise is, I think it's perfect, right? So, Dr. would you show us angiograms a little bit, it's not too definite, we can evaluate the
Looks great.
minimal. However,
2 millimeter depth,
right?
Perfect.
Is it okay?
The mitral leaflet movement is very good, so no definite probable leakage. So diastolic pressure is around 50. So I think we don't need to do further post-dilatation. So patient already have a pacemaker. So I think I'd like to finish my procedure here after measuring the pressure.
It's beautiful.
Do you have any comment?
Even immediate after, you don't check echocardiographic, PVL or something. You don't like it?
I will check up next time.
Right. It's almost
next.
perfect.
Yeah.
Okay.
Beautiful.
Any other comment on that, Alan? Should we move?
I kind of like this minimalistic approach. What I even would avoid is the temporary pacer. So I consistently pace on the LV wire these days. The need for a temporary pacemaker at the end of the procedure is less than 5%. So less than 5% of all patients leave the cath lab with a temporary pacer. We don't even put a venous sheath anymore. That's all beyond us. I also, we also walked away from systematic echocardiography in the cath lab. There is a very poor correlation between the gradients, but also PVL assessment with an echo in a supine position versus a pre-discharge echo in the left lateral decubitus position. So that's why we abandoned it. We do integrated analysis of the paravalvular leak based on aortography and AR index these days.
You put a temporary pacemaker in for a patient with a right bundle or not even for a right bundle?
So that's a good question. So we have a policy of prophylactic pacemakers in patients with a right bundle branch and a QRS duration above 160 milliseconds because we know that there's a 75% chance of pacers.
So pre-procedure.
Yeah.
Good. A nice case presentation, Dr. Ahn. You have to evaluate the echocardiographic evaluation, right?
Yes.
All right, you want to move the second cath lab. Dr. Park, Duk-Woo, it's great cases. All right, can you hear me?
Okay.
Dr. Park?
Okay, I can hear you well, and
Okay,
thank you very
great.
much. Okay.
We have many.
So thank you very much.
Distinguished
the
faculty
moderator.
here, so you have to
Okay.
consider
Okay.
that.
So I'm the DW Park, and we're gonna start the second case. I'm the welcome our old friend Alan and David and Kentaro and Nico and many another famous panelists and faculty. So I'm gonna introduce our team. I'm DW Park and the Do-Yoon Kang, our the valvular interventionist professor, and Yeung-Guk, our senior fellow. So, and today we prepared the two case and the relatively simple, not hard case. Tomorrow we prepared a very difficult and hard case, and so we're gonna start the case and Do-Yoon. And can you present patient background?
Yes. Good afternoon. I'm Dr. Do-Yoon, and I will introduce our case. The patient is a 71-year-old female with a history of hypertension and admitted for dyspnea with functional class 2. And she also had the history of syncope. Next. And her medical history has the hypertension and dyslipidemia, and STS score for isolated AVR was 1.97%. And next. And the EKG shows the right bundle branch block. Next. And chest PA showed mild cardiomegaly. Next. And we evaluated the echo, and the ejection fraction was normal 65%. And trans-aortic valve velocity was 4.3 meter per second with the peak and mean pressure gradient 74 and 41 millimeter mercury. And her aortic valve area was 0.79 square centimeter. She also had a mild MR and concentric LVH with the LA enlargement. Next. This is the echo. Next. Same finding with the previous described mild MR and CVIS. And we usually evaluate the CT, only CT for TAVR planning. And this is the reconstructed view of the aortic valve complex with a 3-angio dedicated program. And annular short diameter was 18.3 and long diameter was 24.2. And annulus area was 354 square millimeter, and annulus perimeter was 68. Next. And we also evaluate the area of the sinus of Valsalva and check the sinus to annulus area ratio. It was 2.2, that means sufficiently large compared to annulus area. And ST junction was also bigger than annulus, that would be safe for the landing. Next. And LVOT, there was no severe calcification or other anomaly. Next. And this is the shape and amount of the calcification. And the total calcium volume over 850 hospital unit was 100, about 100, a relatively small amount. But there was some partial fusion between NCC and LCC with some calcification. Next. And this is the shape of the calcium. And the approach site, aorta and iliac artery was relatively clear. Next. And also evaluate the coronary height. And left coronary height 10.1 and right coronary height 15. Left coronary height looks a little bit lower, but as I described, the sinus of Valsalva is large enough, so we did not consider coronary protection. Next. And iliofemoral artery is good. Next. And also we evaluated the aortic arch anatomy for the indication of the cerebral protection, and brachial and carotid artery was clean. Next. And this is a sizing chart when we consider the SAPIEN 3. If we select the 23, we can achieve the 15% of the area oversize. Next. And this is the coplanar projection that is predicted in CT. Next. And this is our initial plan with the SAPIEN 3 23 millimeter with a femoral approach.
Okay, so I'm gonna summarize this patient and briefly, and anatomically relatively simple. We had a very nice discussion point for the relatively young patient, the 71-year-old female. STS score is quite low, and anatomy is relatively good. So I think this patient would be, there are many debatable portions. And the first is a 71-year-old female is how can you do heart team discussion, SAVR versus TAVR. And on the basis of EU guideline more than 75 and US more than 65, this is absolutely borderline. Yeah. And this is like a relatively young, the low risk patient. How can you do SAVR versus TAVR decision making? And second one is about we're gonna do sentinel protection device, and this is a relatively young patient. Absolutely, protected TAVR trial was published, but still valve intervention is still concerning about which patient would be benefit. And given that the low risk population usually has quite low rate disabling stroke, and the further study absolutely required which patient and which anatomy could maximally benefit the use of the sentinel protection device. And technically this patient was some fusion calcium, and initially baseline RBBB. So we will discussion about the implantation technique even in the SAPIEN, the valve implantation is areocaudal cursive overlap high implantation technique was recently recommended quite well. And how do you think about the moderator on the panel, that would be some debatable the point for this relatively young patient.
Relatively very simple, right? Good morphology concern. The calcium amount is almost 100 something, is very low calcium amount here. So what device would you select, Dr. Park, and the size-wise? Could you explain that one?
Yeah, so and this patient we are planned to 23, and the nominal the size is 15% is oversizing. This patient would be some concern about which valve would be optimal. You know, if you consider and the effective orifice area is concerned about the process is a patient mismatch, we should always bigger size. If you select the Evolut, and we can put the 26, and if you select the Sapien, we can put the 23. Given that the long-term durability and the long-term outcome and which valve is the best, such relatively small annulus would be also a very debatable point.
Would you show us the table CT algorithm percent oversize table, please?
The CT algorithm.
15%.
Yeah, okay,
all right,
here.
that one exactly
15%.
right. If you choose 23 Sapien, anyway, the area oversizing is almost 15%, right? So we have
Yes, right.
some cutoff value in terms of a very mild calcification. Actually, the cutoff value is 10 to 15. And then you're gonna accommodate it, to overinflate or something like that.
But what also is interesting in this oversizing discussion is the perimeter oversizing is only 3%. Right, so basically there is this lot of discussion. Why do we need to size based on the area? That is for balloon expandable valves, but in the IFU for an Evolut, it's the perimeter, right? So I think the oversizing in this particular case with the Sapien 323 really is not a real issue, and I would agree with the team here to proceed with a Sapien valve. Why? Because it's also a horizontal aorta, as you can tell, and there is this right bundle branch block already. So if you look at the pacemaker incidence, it always will be higher with a self-expanding supra-annular functioning Evolut valve than a Sapien. It is also not zero with surgery, so I think the pacemaker issue should not be a matter of debate in the heart team discussion. And in Rotterdam, that's my final point, I would select in this case, if I would not want to proceed with a prophylactic pacemaker, I would select an accurate valve. Why? Because it really works well on the horizontal aorta, and it has the best-in-class pacemakers.
Okay.
Not a lot of calcium.
Good point.
I mean, certainly when there's not that much calcium, you want to be a little bit oversized on the range that you want to select because you don't want to have it embolized. So
You're going to discuss later. Also,
yeah.
proceed.
Okay, so and here and we try to put the Sentinel protection device, and this is the strap of the Sentinel, and at a 30-degree we check it up the Kujushos angle, and the overall size and the angulation is okay for Sentinel device, and you can see the size measurement is quite fulfilled the overall criteria of the Sentinel. So I insert over here, and the wire is usually we're gonna use the household wire, the Xion blue, and then over here. 좀 더 들어가야 되지?
좀 많이 들어가요.
Okay, over here 여기 정도에서. 오케이, 여기 좀 테스트 해보자. 테스트 레디? 여기다 그지? 오케이.
하겠습니다. 테스트.
오케이, good.
이게 지금 첫 번째고요. 저 뒤에가.
알았어. 조금 더 나와서. First, and we will.
더 내려가요.
Okay.
But I think you really have to insert a little bit deeper now first before you deploy the first filter. So go a little bit deeper.
Yes,
That's
over
it.
here.
Yes, yes.
Okay,
And here you can deploy the first filter.
Yes, great. So over here and
So that's perfect. If you keep it there, perfect.
Okay, got it. And then make a band over here.
So what you can do is you can pull the wire back into the delivery catheter like that, and then you use the number 2 knot
Pull back, yeah.
and pull back a little
Okay.
bit.
Yeah, otherwise hard to bend.
들어오고 있지? Pull back the little bit and then make a bend.
Alan, would you do
Okay, good.
sentinel for routine?
Okay, good.
No?
As always, a debate, either do it in everybody or don't do anything in anyone. So it's almost hard to figure out any particular high-risk set. But sometimes, if bicuspid, a lot of calcium, we pre-dilate, we do that. And if the patient asks for it, we definitely do it.
You mean
That's kind of...
selected cases for
But I don't know how to select it.
We do them for all the patients, but that's a New York thing. I think if there's, this patient has no risk factors that are high for a stroke, but it's very unpredictable. I think that is the problem. We're still trying to get the answer if this really helps or if we're just making ourselves feel better.
I'm also a big proponent of this, but obviously we have the protected TAVR trial that was a negative study, but there was a clear signal in fewer disabling strokes in the patients who were protected. So basically also my practice is to protect if it's anatomically feasible.
Yeah, I think the problem is that predicting is just not there.
Not there. You ready?
Even the things we think like bicuspid valves, valve and valve.
So I think position-wise is very excellent, and we're gonna do the straightforward. So I'm wondering about the current, the sentinel indication in the EU and the US, and which case you usually do the sentinel device, even in Japan, in Kentaro.
Unfortunately, we don't have the sentinel in our country.
I will also tell you that in the United States, the data right now still are that only about 16% of patients undergoing TAVR get embolic.
Yeah.
So the vast majority do not. I don't know what in Netherlands.
Same, because there is no reimbursement in Rotterdam. It's 60-ish%. We dropped a little bit because in the low calcium valves we no longer use the filters. But if there is significant volume of calcium, and by the way, in the community there is this sense that bicuspid aortic stenosis and valves might be procedures at risk, but those were remarkably underrepresented in the protected TAVR trial, only 7 or 8%.
Maybe that's why. That's why.
This is Teflon wire.
Clearly it's a little bit of random process. That's why it's so hard to know when did the piece come off, and we can't tell from the outside.
And you know what nobody is disputing is that there will be debris in almost every patient, right?
That's why you need to use it in everyone. It's almost impossible to pick one.
I really do think there are two right answers, and there are everybody or nobody. The third answer doesn't make sense.
You can argue from no one's standpoint, from an economic standpoint, say, hey, we don't use all.
Or a benefit. We haven't put all the benefit yet.
And if you don't know how to use it, waste a lot of time and cause more harm as well. So it's really either one or the other.
And I think it's that to me is the clear part. There's only two ways to use it.
한번 루트 보여줄까?
Particular for these patients, actually, DW wanna show how to. To sentinel something is, and we have still conducted some part of a random study, so continuing to the TAVR study in terms of brain MRI evaluation after 6 months later, and so we're gonna make some good, perfect.
You want to be practice that so you can use it when you need to.
Yeah, I think I fully agree. The Sentinel device's price is much higher, and even in the South Korea, and more than 80-year-old, and the government reimbursed 95% the procedural fee. But given that Sentinel device is much costly than the TAVR itself, so I think routine application of the Sentinel still some problematic. Okay. So, and some physicians insist, and such like a low-risk population in concept, if you think about the sequelae of disabling stroke, much catastrophic even in the younger patients. So the reason why they recommend even in the younger patient and the routine, the sentinel would be much, considering the sequelae of the disabling stroke.
So this patient's aorta looks a little wide as well. So something to think about down the road is that whether she will need something more for aortic replacement.
Okay, could you show us the pressure gradient? Good. So, and you can see and the monogram and the aortogram. Okay, we can see the well, and there is quite the pressure gradient, and this patient symptomatic, also presented with the syncope. So we do and straightforward the TAVR procedure using the SAPIEN 3 Ultra. Okay. So and still concerned about the long-term durability in the small the annulus. That would be much considerable in the East Asian population, and looking at the Ocean TAVI registry, and 20%, my memory is 20%, and 25% put the SAPIEN 320 or even 23, and the small size of the valve. Is Kentaro, and can you comment about how device selection in the Japanese population with small annulus? That would be is a matter of debate.
Okay, thank you very much, Leader. Actually, we have a lot of patients with small annulus, but sometimes we use 20 mm SAPIEN 3 or 23 mm average FX for the patient. But we also need to take into account the body surface area. And usually this kind of patient has really small body surface area. That means the severe prosthesis patient mismatch was noted in only 0.7% in our Japanese group.
위에 보여주고 AP로 그대로 또 나볼까?
And
we also
we see a 20. We're thinking we need to put in a 20 millimeter S3. We take a big step back and think very hard about using something else, because again, the U.S. patients don't have the small body surface area. They have a lot of patient prosthesis mismatch if we use a 20. Sometimes we have to, but we don't like to.
So, and I know the SMART trial is comparing the Evolut versus the SAPIEN for small annulus is actively, the recruiting the patient. David, how do you think about the SMART trial? That would be reasonable, or?
Well, I think the SMART trial is fully recruited, so it's all enrolled, and I don't think we're going to get. Maybe we get. Nicolas, when we're going to get results soon, because it's a 1-year endpoint. But the problem with the SMART trial, I think we need to wait for the 5-year data to really see if it makes a difference, because the study is set up with an echocardiographic endpoint for the primary. But I think what we all want to see is whether there are rehospitalizations for heart failure or early valve failure.
Okay.
Something clinical, not mechanistic. So the jury is out. We wait, and then we'll still be waiting.
Okay, so I think this is a slightly area coral view, and now is after publication of the Samuel Kapadia, even the SAPIEN valve series, they recommend high implant technique. It's such like some high risk of the pacemaker event rate. Could you comment on that? Is a high implant technique and the loosened terrain, and that would be make sure is a high implant is the 100% or gel, something like that. Could you comment on that? Is a SAPIEN valve in high implant technique would be beneficial? Okay, test.
I mean, high implant give you hopefully a better EOA valve area. But in this not very calcified valve, I wouldn't aim for too high.
Contrast. Okay, inflate. 1, 2, 3, 4, 5. Deflate. Wait. Okay, pacing up. This is our Asan medical rhythm.
We really like how you do it together too. It's very, very team building.
Like some center is very quite fast and sometimes it's very slow. There is their own the rhythm in the Cedar Sinai and Colombia and something like that. Okay, so here so we will check it up angel. 이렇게 한번 찍어보자. Okay, pre-shot. Okay, I think its result is good. So and then is flow measurement. So and I also fully agree in Rico comment, and there is a big discrepancy about the non-invasive echo measurement and the pressure gradient versus and the invasive monogram measure the pressure gradient. That sometimes during the echocardiographic follow-up, some patient is showing the pressure gradient is going up by echocardiography. We will ask that patient to admit, and we do invasive measurement. There is a big discrepancy. So, and Nico, is how do you do in your center is for such discrepancy?
Yeah. So when the invasive gradient at the end of the procedure was sufficient, by pre-discharge echo, I see that there is a discrepancy. I don't do anything. So I'm happy, and I can accept maximum velocities of 3 to 3.2, 3.3 meters per second. That's not a problem. The problem comes when at the 30-day or later echo, you see a continued increase in velocities. And then my next step would be to do a CT scan, because you can have early leaflet thickening and reduced leaflet motion. So that is something that we need then to exclude. And obviously you also studied that in the TAVR trial.
Okay, the flush. Okay, will shows the hemodiagram. Okay. Okay. 여기 그래 뭐가 안 맞는데 프레셔가? 다시 한번.
Yeah, the flush did.
아빠랑 차이가 있는데.
Aortic pressure minus.
Yeah, it's kind of damped in the aortic pressure. Probably has contrast in it.
And re-zeroing, that's also.
It's just a damp
re-zeroing.
It's not, doesn't look right.
So did you inflate with nominal
There you
volume?
go.
Yeah, so we nominal volume. Okay, so looking at this hemodynamics and AR index, at least 30, and quite nice result. Then there is no pressure gradient, and then we removed the pigtail, and then we're gonna check the final.
No echo evaluations.
So and usually sometimes do, and today could you show echo number?
So the reason that we do an echo real quick is just look for pericardial effusion. Just sometimes, especially if we still use transvenous pacing and old ladies, just to make sure that doesn't happen. We don't check gradient. We don't really.
한번 연결해
It's
주세요.
just to make sure there's nothing surprise us when we go
아까
to
그 뷰 좋네. This is quite the excellent view, not TE. This is a transthoracic echo,
transthoracic,
and there is no effusion, and this patient has a mild MR, and could you show us color? Good.
Perfect.
It's a mild MR.
So DW, the only concern I have with this case at all is the frame of this sapien extends all the way over the top of the left corner.
Yes.
And so what will you do if, and she's young?
Yeah, I
so
think
you're going to be back.
This coronary angle, and there is some enough space.
Yeah.
Sometimes is a high implantation technique using sapien that would be beneficial to avoid permanent implantation. As David Cohen commented, and if you're gonna do high implantation technique, the next stage coronary intervention quite sometimes difficult. There was an issue. This is the both side of the sword. Yes.
Yeah, I'm not even so worried about a coronary intervention because her coronaries are pretty normal, but I'm worried about the second valve here and causing a neoscope that goes all the way to the top of the left main.
Okay. 여기서 찍어볼게 테스트.
So you may have to do a basilica, even if you don't like to.
Okay, angel. 자, 풀샷. Good. There is no AR. Absolutely nice result. And then we will do REO, the cranial view. There was we would you like to make sure its configuration is well open over here? Good. So, and looking at the ECG, this patient is initially slightly, bundle branch block and the widening QRS. Now is slightly better. So, for this case, we would like to usually keep the 1 day is a temporary pacemaker,
Yes.
and the tomorrow. Most of the cases nowadays, we do annually 400 TAVR case, mostly use the sapien valve. Overall, the pacemaker rate is it? Could you comment on that?
6%. Yeah.
6%?
Yes.
Yes.
Yeah, it will be 6%, I agree. But this patient has a total AV block already, as you can tell on the EKG. And again, the likelihood that this patient will end up with a pacemaker is definitely more than 50%. So the disadvantage here is that you will have to keep the patient for a little bit longer in the hospital for prolonged monitoring to make sure that there won't be a pacemaker, a formal, persistent total AV block or whatnot. So that would be the reason why we at least would do a prophylactic pacemaker here.
Okay, we're gonna show us.
In the US, we couldn't do it. We could not do it because of it.
And then
we would not get paid for the pacemaker.
Retrieve and the T-star filter, and then push.
Meaning
the
prophylactic
center.
pacemaker, just put it in anyway, you mean?
That's what we're doing. Yeah.
And then
We won't be
It
able to
depends on the it depends on some criteria, right? So right bundle branch block in combination with a QRS duration of more than 160 or a left anterior hemi block.
and then
That would be an argument in favor of prophylactic pacemaker. The one exception is if we would select an accurate valve in combination with a longer membranous septum.
Is that? Are there other centers in the Netherlands doing that approach of?
Oh yeah, and Copenhagen is also doing the same thing. So and Didier Toulouse is also doing that now.
It won't be possible in the States for a long time.
Well, Jung-Guk,
So
congratulations.
We
Yeah,
show
excellent.
has a relatively straightforward case, and tomorrow we prepare the much difficult case. Thank you.
Beautiful,
Thank you for joining.
straightforward, but still have a lot of nuisance to go through. Thank you.
Thank you. Thank you. 포지션은 좋다, 그제? Okay.
All right, so we're going to come back to the arena that we have the pleasure of Dr. Seung-Jung Park to make some opening remarks of the 12 AP valves and structural heart symposium. SJ?
Thank you. Good afternoon, everyone, again. It's my great pleasure to welcome you all to the AP Valves and Structural Heart 2023. On behalf of organizing committee, so I would like to express my sincere gratitude for your participation despite the typhoon warnings. As much as you join us, even in the bad weather, I hope you have much more rewarding time during this meeting. For 2 days, there will be 13 live case demonstration from the 5 different international cardiac centers based in Australia, China, Japan, Korea, and United States too. And inspiring lectures will also be followed, covering various topics about the complex TAVR, mitral, TEL, and so on. This conference will feature clinical case presentation, training centers, and satellite symposia as well. So, do not miss these opportunities to get updated knowledge, talk about the interesting clinical cases with each other, and build up your friendship too. I hope you enjoy these 2 days compact educational program. Thank you.
So we're going to have SJ to give the first lecture to talk about the 10 years journey of Asan Medical Center's TAVR experience.
14. Thank you. Exactly.
14.
Yes, 14 years journey. So our
Papers say 10.
TAVR procedures. Brief review about the current status of TAVR 2023. If you look at the guideline, it's not changed. The severe symptomatic AS, just according to the ages, more than 65, transfemoral TAVR class 1, and less than 65, depending on age, SAVR, still class 1 indication, or cut off age is 75, more than that TAVR, less than that all other patients, TAVR or SAVRs, unsuitable for TAVR procedures. So, practical point of view, I would say patients who need a tissue valve, actually TAVR, so safer for the only unsuitable TAVR cases. Right. Well, first AMC, our TAVR cases was started at 2010. We started a little bit earlier. And nowadays we do TAVR cases 300 per year, total number 1,500 something. Current 30 days outcomes in our hospital. Procedural success rate is 9.5%. Right, to believe or not, believe anyway. All-cause mortality 1.3, major stroke 0.3%, and vascular complication 4.2, permanent pacemaker 6.8%, PVR moderate to severe 0.4%, almost perfect. I do say, what's difference? So I would say heart team collaborations, everybody know that, and a minimalist approach, MAC procedures, and I would really emphasize our CT algorithm for device selection. Pre-TAVR medical CT measurement is very important part to make a good, procedures. Heart team collaborations. Our smart cardiac surgeons send the patient to the cardiologist for the TAVR, for the AS patient. That is quite enough, right? We don't need any other comment for the collaboration concern. Minimalist approaches, no general anesthesiologists, no TE, 30-minute procedure, so with live demonstrations. Without talk, it's just a 10 to 15-minute procedure. No complication. One day stay, discharge on Thursday. Almost 99% we do minimalist approach. All right. I would focus on our CT algorithm for size selections. I think it's a major key. We have lots of data about that one. 9.9%, 9.5% procedural success rate is really related with the CT algorithms. Anatomy risk factors for TAVR procedures: valve size, heavy calcification, coronary height, the disease status, porcine aorta, bicuspid, aortic valve, aorta pass, etc., etc. We measure aortic, iliac, and the femoral anatomy, annulus size, structure around the valve, sinus of Valsalva, ST junction. Just you've seen the CT, algorithm. Last two cases, our TAVR procedure, LVOT. Measurement, calcium amount, distributions, coronary disease status, and height. Aorta, iliac, femoral artery anatomy, access site, porcine aorta, etc., etc. And also size concerns. So we measure the areas for the balloon expandable, Sapien series. So we measure the structure around in terms of sinus of Valsalva ratio, ST junction ratio, compare with the annulus area concern. That is very, very much important, factors. The reason why sometimes, big sinus in a large calcium amount is not much risk for those patients. So look at this calcium amount average in our case data analysis. Every total calcium 350 and very much heavy calcium. We're going to measure the amount, location, and calcium distribution too. For particular this case, look at this. Outflow tract extended calcium is very top risk factors in terms of rupture, something like that. All right, coronary height here, 10 millimeter for the left side, the low coronary height, less than 10 between the two. We measure the left coronary cusp leaf length, 16 millimeters sometimes, and moderate and a heavy calcification here. And we measure the sinus Valsalva ratio is 1.6. Just you may not remember the average is 1.85 something, and the bigger than that is more safer than that one. So for particular these cases, very high risk of coronary obstruction. All right, I will show tricuspid very simple, quite simple case. It's a moderate calcium, so 670. We choose 10% oversizing. We want to choose the 26 and 2 cc overfill. Balloon size make a 23. Exactly, we can make that one. So calcium amount, based on our data, amount is major disaster, major enemy is for the device sizing. And so we measure that based on the calcium amount, mild, less than 400 something. The cutoff value is 15. 10 to 15% overfill. Just the second cases, the Duk-Woo perform. Not too much calcium, 100 something. So we want to make a 15%, over area oversizing here. Moderate calcification between the 400 and 1,000. We measure the less than 10% oversizing, and after that, we're going to do the overfill, small amount. Severe calcium, less than 5%, bicuspid aortic stenosis, and heavy calcifications, almost the same sizing with CT based on that one. So we're going to make using the balloon volume accommodation, so overfill, underfill, 1 cc, 2 cc for 26 case, 2 cc, less than 2 cc. Anyways, you can make a very different size of a TAVR device. All right, bicuspid aortic stenosis. Look at that one. It says annulus area, relatively long diameter is 28. Calcifications, moderate calcification, 600 something. We're going to choose 29, 3 cc underfill, can make it just a match, 2% overfill, and we do just 2% oversizing, and after we're going to have some almost perfect results without PBL, something like that. So I would say there are many issues in terms of a really high procedural success rate is really related with the pre-CT algorithms, pre-meticulous evaluation. All right, clinical outcomes basis. We prefer balloon expandable, sapiens race. Still, average age is 80. STS score is 4, very low, patient subset. Many comorbidity status, and peripheral vascular disease 4.2%, very clean, normal ejection fraction average. And procedural outcome is really procedural success rate of 99.5%. This is based on the data. Coronary obstruction 0.2%, pulmonary pacemaker 7.9%, and PBL more than moderate 2.7%. Is relatively good. And a little bit different, pulmonary pacemaker rate as a co-valve and balloon expandable here. And 30 days outcomes, all deaths 1.5, cardiac deaths 1.1%, disabling stroke, very low incidence, 0.6%, fatal bleeding 1.3%. 1 year outcomes 8.4%, all deaths 2.2%, cardiac deaths, disabling stroke 1.4%, still very low, and overall outcomes 2022 last year's 1.3% mortality, very low, 0.3% stroke, pulmonary pacemaker is 6.8% here. So minimalist approach we separate. Actually, we cannot compare side by side. The reason why in the later part of our experience based on the MAC procedures, conscious sedation without general anesthesia, and so we cannot compare side by side. However, all right, I want to show the procedural outcomes here. After the MAC procedures, very high procedural success rate here. Pulmonary pacemaker 7.3%, and then less than 10% average constant PBL, 1.5%, very much decreased there. And also, all deaths, 0.9%, very low incidence. Disabling stroke is 0.4%, and disabling stroke and deaths at 1.5%, and the breathing 27%. We can compare, all right, MAC procedures getting better procedural outcomes and procedural success rate dose. So we cannot compare side by side balloon expandable and self-expanding. The reason why is all the experience we do, co-valve, and however later experience mainly balloon expandable. So I want to show some, trend. You cannot compare side by side. However, still the self-expanding has a little bit higher new permanent pacemaker and a little bit higher incidence of, PBL concern here. So, all right, so I would say kind of a SAPIEN, actually co-valve is quite similar. However, there are some trend in terms of a higher incidence of a permanent pacemaker rate, a little bit higher incidence of a PBL. So whenever you choose tissue valve at any age, at any case, TAVR has become the standard of treatment in patients with a symptomatic severe aortic stenosis. SAVE would be considered only for patients who are not suitable for TAVR. Thank you.
Maybe we will reserve the questions to the discussion session at the end.
You introduce yourself? Well, why not?
Our next speaker is Alan Yeung, who's our moderator, who's going to be speaking about new device platforms to prevent complications.
Thank you, David, and thank you, SJ, for having me back. And certainly, no storm can keep us away. This topic is relatively difficult for 10 minutes. So when I was preparing this, I thought instead of going procedure is try to really look at the overall picture of structural heart interventions. For example, TAVR, TMVR, or is it TEER, or is it tricuspid intervention, could be left atrial appendage closures, to see whether there are some principles, which area we should work on to try to decrease complication. Given the time, I'm going to exclude left atrial appendage closure because it's slightly different in terms of the needs. So what are the typical complications of structural heart interventions? Obviously, we're delivering pretty big devices, rigid catheter, large bore. You have to kind of get through something, steerable, and you have to look at it, sort of imaging. And also accuracy, how well you want to do something, whether it's TAVR or it's TEER, that you have to be really looking at the position, too high, too low, lateral, medial, and obviously both on these type of procedure. You don't want embolization. And durability is obviously the long-term outlook, cerebral protection. And obviously for each procedure, there's specific complication, whether it's perivalvular leak, single leg detachment for TEER, and also TMVR, for example, LVOT obstruction and coronary obstruction. So I'm not going to be able to touch on everything, but I'm going to try to give you some of sort of flavor what has been working in different sort of device companies, how to improve the outcome. So in patient standpoint, obviously, increased BMI is a big problem in terms of, for example, access. Small height or tall patients, rhythm, atrial fibrillation, decreased ejection fraction, coronary disease, and peripheral vascular disease are all clinical factors that potentially lead to complication which need to be mitigated. So let's touch on large bore closure. So obviously, the standard we do is obviously using the Pro guide, but now I'm not sure where it's available in Korea. This is the Pro style device, which is an improvement, I think, from the original Pro Glide device. The reason is that it basically gives you more secure suturing because the needles are stronger and therefore can go through sclerotic, calcified lesions, and ability to determine the depth, how deep you need to go in, so you can actually later on when you put the sutures down, knowing that you have reached the vascular surface. So I think this kind of device, why did we use two before, is really sometimes we're not quite sure both will be anchoring, therefore you use two for security. But as you know, many trials now show that you can actually use one of these devices and use a vascular closure, for example, angioseal to finish up, which may have less complication. So other choices are obviously in the US, we have this Mentor device, which is a large angioseal, if you may. It seems like it's simpler to close these with a big sort of anchor and a big glob of sort of collagen on the top. But as you know from the various trials that, whether it's a single arm studies, these large bore sort of closure device still has issue of vascular complication that seems to be a little high. And when you look at the control trials, certainly Mentor versus 2 ProGlide, some of these trials, the data still shows that it's easier, maybe a little quicker, but at the same time, you have more vascular complication, and you might end up with more endovascular bailout as well. So it's not free if you want to make something a little simpler. I think for all structural intervention, imaging is the key, really, whether we can improve on the imaging, getting a new modality. So for example, in many structural heart interventions, I think the availability of the eyes in a 3D fashion, hopefully in the future 4D, allows you to see certain structure of the heart that's very difficult to see by with traditional, definitely not transthoracic, and even with TEE, could be quite difficult as well. So these devices are getting better by the day, and obviously now allows you to get very good pictures of the heart. And why would you need ICE? Has obviously ability to reduce some fluoroscopy time, and you actually don't need to have another person doing the sonography. You can actually control the ICE yourself, and obviously need some training, need some ability to understand the views are a little different from TEE. And again, less complication. I'm sure everyone in this room has patient that undergoing TEE and has a complication, whether it's in surgery, whether it's in structural intervention, typically esophageal injury. That could be quite devastating. And obviously the cost could be lower as well without extra person, extra time. I'm not going to go through this, all the advantages against CTE versus 2D ICE. There's still some sort of discrepancy, but with 3D ICE, you essentially have all the advantage of TEE plus all the other sort of improvement as well. I'm not going to go through this too much, but to basically say, well, 3D ICE can give you certain views that you may not be able to get from, for example, in this particular 4D version of the plug. Not talk too much about, but it's essentially in the future, I still think this is something that we've been promised to be able to do for a while, is really EchoNav, allow us to fuse echo pictures from TEE or ICE and on top of fluoroscopy, because we are used to looking at 2D fluoroscopy, but by layering over the 3D pictures from ultrasound images, I think help us to guide through many different devices now, sort of add another level of security as well as accuracy. I think steerability is really one thing that in some of these devices need to be improved. So that's why the TriClip Gen 4 transcatheter valve repair system is really an improvement, because tricuspid has always been difficult to do because of the way to angle down into the tricuspid. But these new devices have ability to control flex to the tricuspid valve, same as any of the steerable guiding catheter. So now really makes things easier, not perfect yet, but allow you to sort of move in height control as well as lateral medial control. So again, these devices, by making it more steerable, allows you to do procedure quicker and more accurate. So how about from the TAVR side, being more accurate, easier to deliver is still sort of a goal. So for example, the Evolut FX system with a new redesigned capsule and a single spine in the catheter allows this catheter to go through, traverse through tortuosity much easier, and allows it not to be moved, meaning that you don't have to push and pull the wire. Pretty much it stays there. And I think that's a big advantage, because in the past, Evolut has to be sort of two people sort of looking at the wire, tugging on the wire, pushing on the catheter to achieve stability. And again, if you look at aorta like this, going through, and then horizontal aorta compared to the older system, you can see that it's much more flexible and ability to deliver the FX catheter easier. We talked about this earlier in cases already. There are markers in the bottom that allows you to do cusp overlap a little easier, that you're just aiming for one spot on the sort of far right view on the fluoroscopy, to allows you to be able to sort of really guess the cusp overlap. I think Dr. Park has talked about valve sizing, which is really now adopted into the X4 Sapien system, that allows you to dial the sizes by changing the infusion volume of the catheter. So allows you now basically have 16 unique deployment diameters on over 3 valves. So I think that's really the future, is to have more precision in terms of the size of the valve that you want to finally achieve, given the environment you have. Similarly, if you look at in this tier world, is that by improving the clip, by making it longer, wider, and more thicker, that allows you to now do many of these procedures using one clip versus 2 clips, which extend the procedure time, cost, and potential complication, because you're weighing on the leaflet as well. So clearly, the G4 system has a better implant time as well as success rate. And the outcome is better as well. So you can see the consistent theme is that by making these devices more precise, more to solving the problem, we make the procedure better and better for our patient. Durability, the one that we want to work on is really how long do these valves last? And so the SAPIEN X4, as you know, is made of the resilia tissue. And the resilia tissue is a new way of preparing these tissues, because most of the time when you use glutaraldehyde to fix these valves, you create sort of areas that essentially attract calcium. So these areas essentially would become more likely to get calcified, and therefore by doing a special treatment, you can get rid of these binding to calcium because of these fat-free aldehydes that is in the valve. So in the X4 system, resilia tissue, essentially you have changed a different way of capping these free aldehyde, and hopefully gives you longer durability. As shown in this slide here is the surgical Paramount valve that, at least in the short term, looks like there is longer preservation of anti-calcification and hemodynamic properties. So I don't want to talk about perivalvular leak, which is the earliest sort of Achilles heels of TAVR, but this pretty much has been sort of eliminated most of the time, whether it is the FX system or the SAPIEN system. By putting the right amount of wrap inside or outside the valve, pretty much we have now reduced most procedure to proper positioning to trace or minimum or no perivalvular leak. So coronary obstruction is still a problem, and we talked about it in cases earlier today. So with the Evolute system, there are markers as well as the ability to sort of track through the system with a single spine. It tends to be able to align, for example, one dot on the commissure between the left and right, and allows you, therefore, have pretty good 90% time commissure alignment. The X4 system also has a built-in system that essentially can turn the catheter and allows you to centralize and move that little red circle that you can actually see this letter C, which is in the back part of the valve, and which basically in the three-cusp view will align to one of the commissure, and essentially pretty much guarantee that you have commissure alignment. So I just give you a quick whirlwind tour of what can be done in many of these structural heart interventions to decrease the rate of complication, as well as improving sort of the efficacy. But obviously, lifetime management of aortic stenosis TAVR forever still has many things that we need to address, because there's no single solution yet. And I think TMVR is a very promising technology, but at the same time, because many of the studies have to eliminate patients with small LVOT, and that's still a great concern, whether you need to do lampoon or do some septal modification, but those are all make it more complicated than necessary. So I think the solution eventually has to be the valve itself that essentially can be dealing with no LVOT obstruction. Again, tricuspid is challenging, and obviously, I think we have to figure out how to deal with some of the RV dysfunction that ensures if you have a perfect tricuspid replacement. So I think those are all complications that are sort of on the table, and we need to address as we go forward with structural heart interventions. Thank you. So I think, SJ, your way of doing volume adjustment really is sort of, I'm not sure whether Edwards is in the audience, is that actually took that and put it in a system. Because there's, you don't have X4 yet, but essentially is the syringe allows you to adjust the volume that you want to get to. So essentially put your system into a more foolproof system. That's X4. Mm-hmm. So you're before X4. Yep.
Leading the way.
You mean, so we, in almost all cases, we do a little bit underinflated, 1 millimeter, 0.5 millimeters, something like that, for the safety concern first. Mm-hmm. And then we're going to do 1 cc more, 2 cc more. So it's quite a safe, procedure.
So I think the X4 builds into the system that you look at the annular area, and then you have a choice of what volume to improve to get 15% oversize, 10% oversize, 0% oversize. So you can dial up that size.
Almost all cases, just adapted volume we used for the first procedures. However, particularly heavy calcified patients, so we do a little bit, low volume first, and then accommodated a little bit,
If you have a
higher
little leak or
volume,
something, yeah.
So, anyways, we started, almost the beginning of our experience, and so we got a strong confidence in terms of meticulous measurement related with the calcium amount, location, sinus valsalva, ratio, something like that, almost perfect in terms of.
I think the concept of this journey that we've been on for the past 14 years, or maybe longer for Nicolas, is very interesting. And we published a paper just last month in Circuit Interventions where we tried to do a little bit of both of you just have done. We tried to look at data from the TBT registry in the United States, where we have a decade worth of experience, to say what has led to the improvements, what specific factors that we can identify has led to the improvements. And it was a very interesting study. So for short-term mortality, so looking at in-hospital mortality, the things that had by far the biggest impact on it wasn't the patients. You would think, oh, it's the patients are getting healthier and healthier. It was not the patients. It was the devices themselves, meaning ceiling skirts, lower profile, meaning more transfemoral access. That was very critical. And then the second thing was procedural modifications, getting rid of general anesthesia and embolic protection, actually. If you looked a little further downstream and you looked at complications, things like bundle branch block, pacemakers, strokes, all those sort of things, now actually there was a part, it was still the procedural factors, it was still the device factors, but there was this big gap. About 25% of the benefit was not explained by anything we could measure. And that is the learning curve. That is what we have learned, what the centers have learned, and also imaging. So I think it's, again, we thought it was a very interesting paper. I haven't seen anyone done like that before, but really trying to understand exactly what was contributing to why we were getting so much better. And I think that helps us with some lessons for tricuspid, hopefully, and mitral valves as they come out, to think about in the same way.
But what I also like from what you're saying now, but also what Professor Park illustrated, that is the importance of CT imaging. But I think, I assume that also in your side, you are interpreting the CTs yourself. Mm-hmm. So what you see a lot happen now in Europe is that the CT imaging and analysis is being outsourced to the companies. And I think that is a big mistake. You really have to master the imaging yourself. Once you're capable of doing that, then you can do the fine-tuning, as Professor Park is saying, like once you see less for this indication, and it becomes more and more patient and anatomy tailored. And I think that is really one of the key changes.
I personally believe we need some kind of protocols, pre-evaluation. For you just mentioned about the self-expanding device, totally different things. At the beginning, we matched the perimeters, percent diameter. However, we too much concern about the calcium amount and something like that. We have to do a little bit bigger device. We have to choose that. The reason why is it cannot avoid in terms of balloon expandable pressure loading and finish that one. However, self-expanding is a continuous pressure for the tissue. It doesn't tissue something like that. And so the basic difference can make a little bit different clinical outcomes. A little bit higher pulmonary pacemaker, a little bit, too much concern about just the self-expanding PBL is a little bit higher, right? So. In particular, balloon expandables, we, made some CT algorithms, something like that. And so we routinely, every day, and can make a really good, perfect, procedural outcomes. And so we believe that one, right?
I mean, TAVR is a relatively simple procedure, a big stent into some spot. But it really depends on a lot of details. If you don't pay attention to details, you can be disastrous, putting a big stent into a wrong place or occlude certain things. So I think the details, knowing the CT, knowing each case going in, the part about doing a lot of TAVRs in the same day, sometimes everybody becomes one person because they are all old, all have AS, and you cannot remember. So I think it's important to review the case before, even reviewing the CT quickly as well. Just remind yourself what this patient is about. So I think that's kind of my take.
Just, right, exactly, some cases, right? Very small sinus and even there are not too much calcium for the left coronary calcium, for examples, right? We can do the, deploy the procedure, something like that. And the very small, however, big sinus with a large calcium, sometimes we can do that. There are enough space to modify them. So very meticulous, measurement can make a really, very delicate, small things care. We can care that, but that's my.
I'm going to be very curious to see what Nicolas shows us tomorrow with the planning software, because I think that, you have planning software because you've built it by hand, but, it would be really nice if everybody had the same planning software.
Yeah, and it becomes visual. Then it becomes visual and easy to interpret.
We have a question.
I have a quick question to Dr. Park. With the use of Sapien Ultra, we rarely apply oversizing over beyond 5 or 6%. So do you think we still need 10 to 15% oversizing?
All right, we need the data. However, we have to accommodate a little bit small, area oversizing would be okay, right? Maybe 10%. We just case is a small calcium, 15% criteria, maybe 10% would be okay, something like that. Right. We need data.
Anything else? Okay. All right. Thank you very much, everybody, for this beautiful first session. Thanks.